everybody, and welcome to the Lupus Forum. My name is Dr. Maria Dall'Era, and I am Professor and Chief of Rheumatology at the University of California, San Francisco in the United States. It's my pleasure to welcome you today. Welcome back to our return listeners to Lupus Forum, and also welcome to all of you who are new to Lupus Forum. We're excited to have you with us. We have a fantastic webinar planned for you today. And now I'd like to introduce my colleagues who will be speaking. Professor Liz Lightstone, who is Professor of Renal Medicine for the Faculty of Medicine and Honorary Consultant Physician at Imperial College London in the UK. And Professor Megan Clowse, Professor of Medicine and Chief of the Division of Rheumatology and Immunology at Duke University in North Carolina in the United States. These are two of the world experts in lupus and pregnancy, and we are thrilled to have them here today. I know that we're all going to learn a lot from their presentations. Before we start with the presentations, just a couple of updates for you. To begin with, this is one of a 3-seminar series that is sponsored by the Lupus Forum. Those of you who are familiar with Lupus Forum, a survey goes out to all the members, and we look at requests for topics from all of you. And these topics were highlighted from our listenership as topics that are important in the care of clinical patients with lupus, and also for lupus education, those of you who speak on lupus topics. The first one has been completed. I encourage you to listen to it. It's excellent, and it's with Doctors Ed Vitale and Brad Rovin, highlighting biomarkers in lupus research and care. The second of the series is today, Lupus and Pregnancy, and the third will be coming soon, which is going to be reviewing the latest concepts from the lupus guidelines with Doctors Ed Vitale and Chris Edwards. Just a couple of housekeeping things. Please keep yourselves on mute for the duration of the meeting. And any questions that you have for our speakers, you can submit through the Q&A function on Zoom at the bottom. So just click on the Q&A and type in your question. And we've reserved some time at the end of the webinar to try to go through some of those questions. Here are our learning objectives: to provide strategies for optimizing maternal and fetal outcomes in pregnant lupus patients by exploring challenges of lupus in pregnancy, therapeutic considerations, and how to improve maternal and fetal outcomes. And here is the agenda. You'll see we have a lot of great topics here to be covered. We're going to start with Dr. Lightstone, who's going to review issues in the pre-pregnancy period, as well as reviewing important points about a patient's history. And then Dr. Clowse will take it away and talk about pre-pregnancy counseling, and then back to Dr. Lightstone for pregnancy course care recommendations, and then back to Dr. Clowse for postpartum management, and then the Q&A at the end. With that, we will start with Dr. Lightstone, who will be discussing pre-pregnancy and patient history.
Hi, everybody. It's a pleasure to be here. And I'm essentially going to introduce a patient who's sort of covers the whole gamut of problems that we see and who will inform our discussion. These are my disclosures. So in the ideal scenario, you have someone is known to have their lupus. They've had their lupus nephritis treated, and they plan for pregnancy. And they plan for pregnancy before pregnancy. So this is our patient. She came to me in my pre-pregnancy counselling clinic in September 2017. She was then a 29-year-old woman of African heritage. She was known to have had prior lupus nephritis. This was this was September. She was getting married in November, so very good planning, and wanted advice about pregnancy. She had a creatinine that was not normal. She had a creatinine of 97, which micromoles per litre, which gave her an EGFR, taking her into the CKD3 sphere, but she had no proteinuria of note. And her history, she'd been diagnosed in 2009. She'd had a really nasty acute presentation. She'd had acute kidney injury, an AKI. She had had a crescentic class 4 lupus nephritis on renal biopsy in 2010, which had meant that we'd treated her with a cyclophosphamide-based regimen. So that's already something to think about in your pre-pregnancy planning. We would have given her ovarian protection with that cyclophosphamide. And then she was in a long remission and maintained on low-dose prednisolone, mycophenolate mofetil, hydroxychloroquine, and irbesartan. She was known to not be procoagulant. She had negative antiphospholipid, lupus anticoagulant, and anticardiolipin antibodies, but she did have anti-Ro and anti-LAR antibodies, another concern for pregnancy. She had never been aware of having extrarenal manifestations, which is quite interesting, and her serology had been normal for years. So, in a way, she was in an ideal position to think about pregnancy. The medications, this you can see here, her creatinine, this was going back to 2016, although not normal, was pretty stable. She had a normal serum albumin and no proteinuria. And she was taking these doses, a low dose of mycophenolate, a low dose of steroid, a good dose of hydroxychloroquine, full dose irbesartan, remained ANA positive but had a negative double-stranded DNA, normal C3 and a slightly low C4, which is often the case in our patients even in remission. So I'm now going to hand over to Dr. Clowse, who's going to talk about the advice and the basis for the advice we give in pre-pregnancy counseling.
All right, terrific. Yeah, so this case certainly brings a lot to it, right? This is definitely the more complicated lupus patient who shows up for pre-pregnancy counseling. That she is showing up for pre-pregnancy counseling, however, gives us a great head start. Because certainly showing up mid-pregnancy is is worse. All right, next slide. These are my disclosures. Next slide. So my objectives today are going to be to help this patient prepare for pregnancy, manage the risks pre-pregnancy, and Liz is going to talk about managing the many risks in pregnancy, and then I'm going to come back and talk about postpartum management afterwards. Next slide. So this is really sort of my overarching vision and what we really think about when we think about women with really any complex disease, particularly complex rheumatic disease and pregnancy. That the key to a healthy baby, which we all want, is a healthy mother, which we also all want. And really involved in that is pregnancy planning, being on pregnancy-compatible medicines prior to and during pregnancy, and controlling their rheumatic disease. Those are really the three keys that give us the best shot of getting from a healthy mom to a healthy baby. Next slide. So if we start off with pregnancy planning, we have data showing that that's actually exceptionally important. If you go to the next slide. When we look at pregnancies that I have followed over a 5-year period in my pregnancy registry, so I collect pregnancy patients that I see in clinic. This is over 100 women with lupus over this 5-year period. We actually have them do a survey when they show up about how prepared they were personally for pregnancy, how much this was a planned pregnancy. It's called the London Measure of Unplanned Pregnancy. And you can see that about 2/3 of our lupus patients were personally ready and had sort of in their mind at least planned pregnancy, but a third were not. And the third that had not planned this pregnancy had higher rates of depression and had higher rates of not taking their pregnancy safe medicines until they showed up in my office, which can sometimes be multiple months. So that's sort of the personally ready, but then there's also the medically ready standpoint. So we looked at these 115 patients and divided them into 2 groups. Those who were medically ready for pregnancy, meaning they had a known urine protein to creatinine ratio less than 1 gram. So they were not taking a teratogen when they got pregnant. They weren't taking anything that would cause birth defects. And they continued their pregnancy safe medicines because they knew what to do, right? They were ready to get going. Again, you can see 2/3 were ready, 1/3 was not, and they had a much higher rate of holding those pregnancy-safe meds. They had much higher levels of lupus activity during pregnancy, and they had 3-fold higher preterm birth and preeclampsia. So planning is super important. So just that the patient is here is a great head start. Next slide. So I have made handouts, actually discussion guides that I use in clinic and many folks do in the United States, that you can actually print off from lupuspregnancy.org. And they walk through the conversation. And this is how I do it. The boxes are numbered on the page. So number one is really helping the patient understand this match between healthy mom and healthy baby. That women who have low rheumatic disease activity are taking compatible medicines or go list medicines have the safest pregnancy possible for them. People who have high disease activity or on any of our high risk medicines have much higher risk for pregnancy loss, preterm birth, and birth defects. You can see I have the safest pregnancy possible for you. That's because safe is subjective. And this patient that Liz just presented is at high risk for many things, particularly preeclampsia, preterm birth, even pregnancy loss with her history of lupus nephritis, even in remission. So she can't have a safe as though she didn't have lupus pregnancy, but by helping her sort of achieve these goals, she can have the safest one for her. Talking to patients about how well they're disease controlled is actually really important, particularly patients like this with lupus nephritis that don't have other physical signs of lupus. They often feel great. They kind of forget that they have lupus, except that they're supposed to take this fistful of medicines twice a day. And so they can often, people with lupus nephritis who otherwise feel well, can often be kind of lulled into thinking that they don't have very much lupus activity. So we talk about how much disease activity the patient in front of us has. We look for minimal signs of inflammation. In particular, the most important thing is minimal urine protein levels. We also want them to have stable and known sort of heart, lung, kidney, other organ involvement. You need to sort of understand where those are. People have always said no flares within 6 months. The data does suggest that. What is a flare is a hard question. So I sort of say not needing a prednisone taper in the last 6 months is our goal. In our data, though, the protein is the most important thing. If you go to the next slide, I think that's what the next slide is. Indeed, it is active lupus nephritis, not non-renal disease, that really seems to drive our poor outcomes. So again, this is from our pregnancy registry. If you hit the button again, you can see that we divided our patients into 3 groups. Those with inactive lupus throughout pregnancy, that's the blue bar. Those with active lupus nephritis in pregnancy, 15 of them, that's the gray bar. And then our patients with active non-renal disease. Those are people who either had high double-stranded and low complement, had bad rashes, a lot of arthritis, that sort of thing. And you can see that the folks who don't have active lupus nephritis, even if they have some level of disease activity, really do quite well. It's really just these active lupus nephritis folks that make us the most nervous. Next slide. And it's the lupus nephritis activity that is the main problem. In this study, we took 3 different cohorts of patients from North America, from our center, from Johns Hopkins, and from the University of Toronto, and we mixed them together into one larger cohort. Active lupus nephritis in pregnancy, only 29% of them had a live term infant if they had active nephritis in pregnancy. So if you look at the graph, you can see the darkest blue is never had lupus nephritis. The middle blue is inactive lupus nephritis. That our patient currently fits into that category, versus the light blue, which is active lupus nephritis. So women with inactive lupus nephritis have outcomes pretty similar to women without lupus nephritis history, but not quite the same, right? Some increased preterm birth, some increased preeclampsia. Preeclampsia is what I actually see the most in my cohort. All right, next slide. So pregnancy compatible medicines, it's important, and ideally do this before pregnancy. So go to the next slide. So here is my sort of list of the meds that we tend to use in lupus and what categories they fit in. Hydroxychloroquine, many of the guidelines recommend that everybody with lupus be on hydroxychloroquine during pregnancy. Azathioprine or Imuran is really our usual go-to medication from an immunosuppression standpoint. Also, other options, tacrolimus, cyclosporin. We certainly use prednisone when we need it in pregnancy, but there's some suggestion that just using it in somebody with quiet disease is really not helpful and actually potentially harmful. There's also drugs that we know can cause birth defects. They're down there on the may cause birth defects list, or our stop list. And you probably know those. The main ones that we prescribe as rheumatologists frequently, methotrexate, mycophenolate, cyclophosphamide, are really the main ones. Also need to consider aspirin in these patients, but usually not until they're already pregnant. All right, next slide. So there are certainly drugs with limited information, right? Fortunately, a growing number of drugs that are available for lupus, but that means we're sort of growing our list of drugs that are insufficient data. So this is sort of my rule for what I do with these drugs. If in my clinical judgment, the women will have significant disease activity without that drug that will negatively impact her, like really negatively impact her or her baby, and there is not a safer alternative, then I lean towards using that drug. All right. So if we go to the next slide, this is how our biologics kind of work in pregnancy for the most part. Rituximab, obinutuzumab, belimumab, Safnello would do that, or anifrolumab would also work this way, similar to our TNF inhibitors that are IgG antibodies. There's really no significant exposure in the first trimester. They don't cross the placenta. Then they start crossing the placenta in the second trimester, and there's a lot of transfer in the third trimester, so that the baby is actually often born with a higher concentration of the drug than the mother had, and then the baby kind of hangs on to it for a longer period of time. So I use this graph when I think about how am I going to use a drug that has limited data, that's a biologic. Do I want to give it early in pregnancy? Do I want to give it later in pregnancy? And what that risk might hold. Next slide. So for the new biologics that are out, I tend to avoid them if possible. Like if I have another really good option, I would do that. Right, that's actually all that says. Go ahead, next slide. No, that was going to pop up on its own. So once we get past the medicines, then we need to think about sort of the other health issues. So antiphospholipid syndrome, thankfully this patient doesn't have that, right? Her antiphospholipid antibodies were negative. Plus, I didn't hear about a blood clot or prior pregnancy complications, so we don't need to worry about this top box. The next one is Rho or SSA antibodies. It does sound like she has those. So we know that those do cross the placenta, just like the prior slide, actually about halfway through the pregnancy. And in about 1 or 2% of exposed infants, it will cause a permanently slow heartbeat, a complete heart block. And so there is nice data for women who've had prior infants and are pregnant again. There's a much higher risk of this happening in those patients, showing nice data showing that hydroxychloroquine cuts that risk in half. So I currently use hydroxychloroquine in these patients, whether they've had a prior infant with it or not, in order to cut that risk in half. And here in my practice, I tend to do fetal echocardiograms, so that really differs by centers. Monitoring and controlling high blood pressure is exceptionally important, ideally pre-pregnancy. No ACE inhibitors or ARBs. So this person's blood pressure medicine is not going to be compatible in pregnancy. Pulling it off of her certainly might increase her urine protein. It certainly also might increase her blood pressure. So that needs to be dealt with ideally pre-pregnancy so that she can be on a safe medicine that actually controls her blood pressure. Blood pressure control is exceptionally important. There's beautiful new trials showing how very important it is to make sure that blood pressure is well controlled during pregnancy. And then we'll come back to breastfeeding in a half hour. Next slide. All right, so now it's back to Liz with the updates.
Okay, so I'm going to skip through these couple of slides. So optimally, you pre-pregnancy counsel, we would have covered all these issues. Particularly, we'd have talked about her fertility because she'd had previous cyclophosphamide. She's never had a baby. She's never had a pregnancy. But also never forget to talk about contraception, because if you don't want someone to get pregnant until a certain time, then they need to use contraception. And we're very bad at discussing that. And we talked about timing and what to stop and everything that Megan has talked about. So here we have her. And then, despite having had pregnancy planning, patients don't always hear the messages that you give them. So when I assessed her initially, actually, I considered she was relatively low risk. We had the PROMISE data at that stage, which had looked at women with known lupus nephritis and known lupus, in fact, and looked at their outcomes in pregnancy, and they'd used really hard criteria. And she was not on, she was on low dose prednisolone. She didn't have any proteinuria. Her creatinine was just under 106, and you always hope everybody has a singleton. But she is non-white. She is on an antihypertensive, which wasn't dissected out in PROMISE because I'm not sure she was hypertensive. It's just that we keep patients on for kidney protection. She's Rho positive. She's technically got CKD3. And then I get the phone call in January 2018. Her last period was clearly sort of a honeymoon night. And she's pregnant, and she'd continued to take her MMF and Sartan. So that hadn't been a very successful pre-pregnancy counselling. And I did offer her a termination because I think you have to go through, well, you know, do you want to continue with the pregnancy? But she wanted to continue, and she was going to stop these drugs pretty early on. The problem was that if you looked back in November, everything was starting to kick off serologically. So having been serologically completely quiescent for years, to the extent that I had thought I would just stop her MMF and not switch her to azathioprine, although initially she looked good, she had this nice fall in creatinine. In pregnancy, you like to see a fall in creatinine of about 10%. In women with CKD, that predicts a better outcome for their kidneys. But then, as you can see, things started to go in the wrong direction. And she had a major lupus flare. And her double-stranded DNA had just started to go up at the beginning of pregnancy and then went right up, and her complement plummeted. And she did exactly what she'd done sort of nearly 10 years before, had an acute kidney injury with a rise in her creatinine. She plummeted her albumin. Her urinary PCR went up to about 6 grams a day. She was nephrotic, hypertensive, and interestingly, she developed arthralgias, which it turned out she'd been having for a while, but she had no idea that was anything to do with her lupus because she'd never had them before. So what do you do now? So think about it. Would you do a renal biopsy? She's about 16, she's mid-trimester, she's about 16 weeks pregnant, 17 weeks pregnant. How do you assess if she's got preeclampsia as well instead of lupus nephritis? And how would you treat her? So I wouldn't do a renal biopsy, and that's not because I don't do renal biopsies in pregnancy. They can be incredibly useful. And if she wasn't known to us and she was presenting with proteinuria and hypertension and we didn't know what was going on and she was less than 22 weeks, I would probably have offered her a biopsy. But actually, she was doing exactly what she'd done 10 years before. She had positive serology that had been negative. This was lupus nephritis, and I didn't need to do a biopsy to prove that. It wasn't going to change my management. I was going to treat her for lupus nephritis, and actually she needed venous thromboembolism prophylaxis because she was nephrotic. So, and you'd have had to delay that if you did a biopsy. It's not going to be preeclampsia at 16, 17 weeks pregnant. But nowadays, we didn't have availability then. We can measure angiogenic factors mid-trimester to actually predict the risk of developing later preeclampsia. And I'll come back to that. And the principles of treatment are pulse steroids and then oral steroids and immunosuppression. Please never treat lupus nephritis on its own or with steroids on their own. They're not good enough. And of course, hydroxychloroquine. Just sort of more generally, when you come across a patient who's developed new onset proteinuria in pregnancy, if they're less certainly than 20 weeks and usually less than 24 weeks, it's usually due to intrinsic renal disease. It's very rarely due to a UTI, which is what keeps happening to some patients. You do all your usual screens for biopsy, for diagnosis, and you would consider a renal biopsy on a risk-benefit ratio. And if the renal biopsy is not possible and you don't think this is lupus, then actually the safest blind treatment for primary glomerulonephritis and to add into lupus would be tacrolimus and not blind high-dose steroids. And there's been some work on this. We wrote a guideline for pregnancy and CKD some years ago that's being revised now. But really only do a biopsy if it's going to change your management. And the data that's published out there to date from Georgina Piccoli is once you go into beyond 22 weeks, there's a much higher risk of major bleeding. That may not actually be true. There's centres around the world where they don't have such access to diagnostic blood tests, and they're much more likely to do late biopsies because women present late. And certainly colleagues in Mexico routinely are biopsying 25, 26 weeks for diagnosis and have very good results. What you shouldn't be using a biopsy for is to diagnose preeclampsia. Okay, so what did we do? We treated her with everything. We gave her methylprednisolone, 3 500 milligram IV pulses. You don't ever need to give a gram of methylprednisolone in lupus nephritis. We initially tried to be quite tight with the oral steroids, but actually, because things were not going right, we gave her 30 milligrams, which we then tapered. We started azathioprine. You should measure the thiopurine methyltransferase levels. They were normal in her, but actually she developed abnormal LFTs very rapidly, so it had to stop. So we added in tacrolimus. Our patients of African heritage need higher doses, and she needed 8 milligrams twice a day to get a decent trough level, and antihypertensives, and aspirin, and low molecular weight heparin, and vitamin D, and folic acid, obviously. So this is a lot of drugs for very little. We actually offered her MMF later in the second trimester and third trimester because you're beyond teratogenicity. But I've only ever persuaded one woman to take MMF later in pregnancy, having terrified them about getting pregnant on it. And there was a certain irony in this case. Anyway, she did quite well. Her creatinine came down, not to baseline. Her albumin stopped dropping, and her PCR improved enormously, and her double-stranded DNA came down. So that was looking good. We looked as though we'd grabbed hold of this episode. And essentially, I quite like this graph, but Megan's covered most of this. There's sort of principles of pregnancy management in lupus nephritis. Pre-pregnancy, you risk stratify your patients, you see how active their disease is, you adjust their medication and ensure they've been in remission. And then really you come to a decision tree with them. Is pregnancy contraindicated? It's very, very rarely contraindicated. Triple positive antiphospholipid syndrome with a bad obstetric history in an older mother who might need an egg donor. I would sigh and say the chance of them having a successful outcome in terms of take-home baby is slim, and they may want to consider not going ahead, but it's incredibly rare. And what's more likely is we say you will have your baby, but not yet, or we go ahead and say green light, go. And once they're pregnant, you need to see them at least monthly. We run a joint obstetric renal clinic, and we have an obstetric physician there, and I can get hold of more or less any specialist I want. And then we monitor them regularly, because what you're looking for are trends, both in their clinical state, their blood pressure. We don't routinely weigh patients in clinic anymore, but if they're nephrotic and you're trying to see they're losing fluid, it's quite useful. And obviously dip the urine every time, send off for a PCR and do the appropriate lab tests. And ensure that they are taking their medicines. Is their disease controlled? And think about swapping things or increasing things. This is from a review we wrote with Fadi Fakuri on treating glomerular disease in pregnancy. And it is quite entertaining because almost every other glomerular disease has treat the blood pressure, possibly steroids or tacrolimus. And then lupus has this very complicated algorithm. But essentially, if they're presenting with a lupus flare in pregnancy, you want to start urgent therapy. Do not delay giving them steroids. But also talk to them about therapeutic termination. You know, if this is a 22-year-old who's got years of fertility ahead of them, all being well, there's some sense in saying, well, perhaps you would consider terminating this pregnancy, getting you better, and then having a planned pregnancy. Many women decline termination, but I don't think we should be making the barrier there. That should be for them to decide. And you want to control disease, and we looked as though we'd control disease. And as I've said, always with immunosuppression. Don't use voclosporin. There is no data on it in pregnancy, and it is not recommended in pregnancy if you're going to use a CNI. I always use tacrolimus. Cyclosporin makes them hairy and gives them gum hypertrophy, so I never use it, but in some areas it may be much more available. And I do use rituximab in the first trimester and generally not in the second or third. If they're already on maintenance therapy and they're fine, this is not the moment to try and wean their steroids or do anything else. I wouldn't have had her on low dose steroid as she was pre-pregnancy, but I wasn't going to wean it before she was getting pregnant. And then you're going to hear from Megan about maintaining close follow-up. I do want to focus a bit on tacrolimus because it's a really useful adjunct in pregnancy. It's safe in pregnancy. There's been a few publications we've published on this. There is an increased risk of gestational diabetes because of the way it works. That's particularly true if they're already on steroids, so they must have a glucose tolerance test. The dosing is a pain. They eat up the tacrolimus and the trough levels appear to drop, but I'm going to return to that in a second. And they definitely should not be discouraged from breastfeeding. We've published on this. They're very low amounts go into breast milk, and certainly term and reasonable weight babies just get rid of it the same rate they get if they're bottle fed. And what you need to do if they're preemie is just do a heel prick to see that you're not giving them toxic levels. The problem is this, that the level of tacrolimus, we measure whole blood levels and the level goes down in pregnancy. And then we end up chasing our tail. And it's quite clear that we are making some women toxic. My colleague in Adelaide, Shilpa Jesudason, has been doing some beautiful work trying to establish an assay to measure plasma levels, which are much more stable through pregnancy. You don't have this drop. And in fact, what you see with tacrolimus using whole blood levels is that you end up overdosing and end up with babies who have a reduced birth weight and at higher risk of preeclampsia in the mother. So we really do need to change how we're measuring it. This assay isn't generally available yet, but we will change. And I do think you have to back off constantly increasing the doses. Okay, so how did our patient do? Well, it was all going pretty well until 34 plus 40 because her creatinine rose again. So you can see this was her flare in early pregnancy, and there we are with another acute kidney injury, which is not good for your kidneys long term. Her albumin drops again and her proteinuria starts to go up. And this is really quite a nasty AKI with a creatinine up to 138. Her PCR had improved to 60 milligrams per millimole, went up to 304, so back up to nephrotic range, and her blood pressure rose. So the question we're always facing is this lupus nephritis or is this preeclampsia or is it superimposed preeclampsia? And in the past, we've generally had to sort of go on lupus markers or sort of our clinical instincts almost, but things have got a bit easier. So one thing to remember is that pregnancy is an acute phase time. So complement often rises in pregnancy. So that's another reason for measuring it regularly, because if it's normal but falling in the normal range, you should start to be concerned. And particularly if you've got a rising double-stranded DNA, that's one very good way of distinguishing this for active lupus nephritis from preeclampsia. You shouldn't have microscopic hematuria in preeclampsia, but we now have these angiogenic factors. And placental growth factor goes down in preeclampsia, and the ratio of soluble fit to placental growth factor goes up in preeclampsia. So some quite old work from the PROMISE study that said if you measured at 16 to 19 weeks in women with lupus, actually you could predict those who were going to have adverse pregnancy outcomes with quite a good negative predictive value. So if their levels were, they had a high PLGF or a low ratio, actually they were unlikely to get in trouble. Now, we're not doing this routinely, and I'll be interested at the end to hear if Megan or Maria are measuring these at that stage. What's been validated in a study from Mexico is that measuring PLGF or the ratio in patients when you're trying to decide is this preeclampsia or not, superimposed or lupus nephritis, you could tell the difference. And I've certainly found it incredibly useful in clinical practice. It's a bedside test. Always when you want to use it, doesn't work, but the kit doesn't work, but it is a really useful test. And it's really important not to miss preeclampsia because the only treatment really is delivery, whereas lupus nephritis, you can carry on treating. And my colleague Kate Bramman's done work showing this is valid in women with kidney disease and hypertension, and a placental growth factor less than the 5th centile predicts delivery within 14 days. But if you've got abnormal kidney function, then actually what is your cutoff for normality may be higher, and we may need to reset what a normal, a low placental growth factor is in pregnancy. I'll mention the thrombotic microangiopathy because it can complicate lupus nephritis and it can present in women with lupus. I wouldn't expect it in this patient in particular. There's lots of variations of TMA, and there's pregnancy associated ones and there's lupus flare associated ones. But actually the only thing that can really discriminate lupus from the dreaded atypical hemolytic uremic syndrome is the presence of schistocytes on the blood film. So if you really think, if you've got a patient who's dropping their platelets, who's got hypertension, whose kidney function's going off, you should certainly do a blood film. And it is important to differentiate them because you can treat lupus nephritis with immunosuppression. TMA, I'm not going to go into today, but there's very different treatments. And preeclampsia, you just want to deliver them. So when to deliver, and that's always your problem. Data now suggests that once you've got to 34 weeks, the baby's brain is relatively safe. So my obstetric colleagues have got very relaxed about 34 weeks as a gestational age. I'm less relaxed because most of your nephrons develop later in pregnancy, and I'm worried we're going to be generating a whole generation of the children of patients with lupus who've got small kidneys and a low nephron number that's going to set them up for CKD in the future. But you're always balancing the mother's health and the baby's health. The mother will always put the baby's health before her own and will want to put off delivery, thinking that extra time is better. And that's certainly true less than 28 weeks usually. But you've also got to look at how the baby's doing. And if the growth scans are fine and the baby's Dopplers are fine, the chances are the baby's fine. But if the baby's shrinking, which is what we often see in our lupus patients, and the Dopplers are beginning to go in the wrong direction, then you should be thinking about delivery. And of course, this is a decision in conjunction with the mother and with the obstetricians. You've also got to think practical. Depends where you are in the world. Have you got level 3 neonatal care? If the woman's renal function's going off and you let her carry on going off, can you offer her dialysis? So those are factors that need to come in. You also need to think generally about protecting the mother and thinking about the impact of nephrotic range proteinuria. VT prophylaxis is an absolute. Once they've got proteinuria sort of 2 grams or more, I tend to use low molecular weight heparin prophylaxis. Treat the blood pressure. In the old days, people were not that keen on treating blood pressure. You should, but you don't want hypotension. Don't even measure the lipids. Lipids go up in pregnancy. Baby developing fetuses need fats. And there's nothing we can do about the hyperlipidemia of nephrotic syndrome in pregnancy. So don't look. Do the glucose tolerance test. And a very important point, these women may end up in renal failure at some point in their lives and may need a renal transplant. They will already have been sensitized by their pregnancies. You don't want to add to that sensitization by unnecessary blood transfusions. So you can give IV iron to maintain their ferritins, and you can give erythropoietin in pregnancy. And I try and avoid transfusion wherever possible. So how did it all go? Well, she'd had a major flare in early pregnancy. We deemed this was likely superimposed preeclampsia. We controlled her blood pressure and she went for induction of labor, but the baby developed fetal distress. So she ended up with an emergency Caesar in July 2018. So delivered actually at 35 weeks with good APGARs and actually a pretty good weight for 35 weeks given that history. She had quite an exciting postpartum time, and I haven't got time to tell you she's had some much more exciting postpartum time since, but it cost her some renal function. We did a biopsy early postpartum, and this showed she clearly had a nasty episode. She had several segmental scars and she had a fibrous crescent and a bit of scarring. She wanted to breastfeed, and you're not allowed to breastfeed on mycophenolate, so we gave her rituximab in that early postpartum period. We weaned her off her TAC. We subsequently weaned her off her pred, and she was put onto MMF maintenance once she stopped breastfeeding, and she was very happy with this gorgeous little boy that she had delivered. But it cost her a lot. So this was when I saw her, when she'd had stable renal function pre-pregnancy. This was when she had a positive pregnancy test. This was her flare. This was her preeclampsia. And you can see she went from a GFR of 59 mils per minute to 45 mils per minute. So serious loss of function, which is really important when you think about her long-term lifetime of maintaining kidney function. And I'm going to hand you back to Megan to talk about postpartum management.
Fantastic. That was quite a hairy case. Oh, am I unmuted? And I think about as good an outcome as anybody could hope for at 35 weeks. I agree. I definitely get less stressed after about 32 to 34 weeks. And this patient had a remarkably good outcome given the situation. I will say it's rare that in my experience that people have such severe lupus nephritis flares going from normal to flaring that much. It seems to be a really pretty small group of patients, except that the patient had to stop her medicines, right? So that's why pre-pregnancy, ideally make the shift early, before, even at the first conversation. If somebody's getting married in 2 months, just stop her mycophenolate and put her on something else right away is often my current approach. Trying to have people delay when they're really ready to go can be really challenging. All right, postpartum management I'm just going to put out there, not that complicated, I don't think. So let's go to the next slide. So first off, a lot of patients are told, I think, some problematic myths. One is that they're going to flare postpartum. I mean, I think every OB in the United States tells a woman with lupus that she's going to flare postpartum. They all come to me. I have patients avoiding pregnancy because they don't want a postpartum flare. We really don't see that many postpartum flares as long as she's taking medicine. Right? So indeed, 30 years ago, we didn't let people breastfeed on any medicine. We also didn't really let them get pregnant on any medicine. So, of course, they had more lupus activity in pregnancy. And of course, they had more lupus activity after pregnancy. But now that we use really good meds, we don't see this. This is an analysis from the Johns Hopkins lupus pregnancy cohort, actually, the entire lupus cohort, comparing people who were not pregnant in blue to those who were pregnant in purple, or the maroon, we'll call it. 3 months postpartum in the bright purple, and then 12 months postpartum in the light purple. You can see as long as the patient was taking hydroxychloroquine, no significant increase in flares. She was not taking hydroxychloroquine in pregnancy or in that soon postpartum period, definitely a higher rate of flares. So she doesn't have to flare. It's a good reason to stay on medicine. Next slide. Number 2, women do not need to choose between treating their rheumatic disease and breastfeeding 95% of the time. All right. So in my cohort of patients over a 10-year period of time, we looked at who wanted to breastfeed. The answer was most, the large majority wanted to breastfeed. And 95% of the patients were on medicines postpartum in which it was safe to breastfeed. So the vast majority can do so. And we did a qualitative study at one point with women with inflammatory arthritis, and we got just these heartbreaking quotes from women about really trying to decide to breastfeed or not. And this was a quote from a woman who said, "For the first 6 months, I flared while breastfeeding, and I would have my spouse hold the baby up to my breast to breastfeed. I was in bed for 6 months." All right, we just heard these horrible stories of women torturing themselves in order to breastfeed when they could have just been taking medicine at the same time and not torturing themselves, or feeling huge guilt of just having to give up breastfeeding. The wording they used was just really emotional and self-blaming for not being able to breastfeed. So this is not a decision that the vast majority of our patients have to make. Next slide. And that is because almost all of our medicines are actually pretty compatible with breastfeeding. So all the medicines that are pregnancy compatible, both for lupus and for inflammatory arthritis, everything that's compatible in the rheumatology world, this is maybe not a rule for everybody, but at least in the rheumatology world, everything that you know of as that is pregnancy compatible is also compatible with breastfeeding. In addition, all biologics, including all TNF inhibitors, all of the newer injectable and IV medications for rheumatic disease, I am comfortable with people breastfeeding on them. They are huge molecules that really do not transfer into breast milk in any kind of sizable amount. And if they do transfer even just a little, the baby is going to digest them, right? There's a reason that we're not drinking TNF inhibitors is because your stomach digests them. So biologics, the guidelines from the American College of Rheumatology, as well as I believe from the UK, as well as from EULAR, everybody is pretty comfortable with really any of the newer injectable biologics. Methotrexate actually also could be considered in breastfeeding. This is like higher level, but it basically has actually a pretty short half-life. It stays active in terms of its impact on the immune system, but it's actually out of the woman's system within 24 hours, and therefore is really out of her breast milk within 24 hours. So if somebody really wants to breastfeed and really needs to go back on methotrexate, you can do that. I generally have them pump and dump that first 24 hours. Medications I avoid, just like Liz said, mycophenolate. It is a small molecule. It has not been measured very really in breast milk, so we don't know how much would cross. Similarly, cyclophosphamide falls in that category. There's a little bit of data about transfer. It does transfer, and certainly it could be hazardous to a small baby. And then all the new oral small molecule medicines. If you hear that it's a small molecule, that means it's probably in the size that actually could cross into breast milk. Also, probably could cross the placenta as well. So at this point, I'm not using any of those, or the new ones that come to the market, I would be more hesitant to use. Next slide. So message 3 is prepare for or prepare to avoid the next pregnancy, right? I always ask people when they show up postpartum, actually usually ask this about third trimester, but postpartum. So what are we thinking about? More babies, right? And usually people are like, oh gosh, not right now, right? Because they're a little overwhelmed. But a lot of women haven't really thought about birth control. I didn't talk about birth control at the beginning, but it is definitely worth talking about now. When women are breastfeeding, progesterone only options are really what OBs will generally prescribe, but progesterone options are now really quite widely available in multiple forms. There's the traditional mini pills or progesterone only pills. There's even a new one, at least in the United States, that has a better half-life than those. There's the injectable depot shots. There's the IUD that has progesterone in it. There's also the contraceptive implant that is also available and is good for multiple years. The IUD and the contraceptive implant are certainly the most foolproof. A doctor has to put them in, and then they stay there until the woman wants to conceive. And so for women who really want to delay pregnancy or not get pregnant again, that is definitely my focus. For women who are kind of more on the fence, we go towards the other options generally. The benefits, I think, also can be multiple beyond just not getting pregnant. And I think for some women, this is actually really helpful to think through. They can help decrease menstrual flow. We see less iron deficiency anemia in patients who are not having such heavy menstrual flow. They can certainly assist with pregnancy planning and timing so that, right, we have a patient who has a really rough pregnancy like this. We say, okay, like we need to put you on mycophenolate now. But when we do this again, how about if we do this a little differently next time, right? And so let's really get us a good, healthy time in between pregnancies and allow us to get you off the mycophenolate and onto safer meds before pregnancy, and really allow everybody to take a deep breath and do it that way. Progesterone-only birth control does not increase the risk for blood clots, which is a really nice option. So it's really safe for all of our women with lupus, as well as for patients with antiphospholipid syndrome. Next slide. All right.
Excellent. Excellent. Thank you very much, Dr. Clowse and Dr. Lightstone. Those were just fabulous presentations. I learned a lot, and I loved the fact that you had this case that ran through and that you integrated in not just important data from pivotal studies, but also your own practical words of wisdom and how we can manage our patients with lupus who are pregnant. I have to say that I still, after all of my years taking care of lupus patients, I still am humbled in the setting of taking care of patients who are pregnant. And just to hear your experiences and your clinical pearls has been incredibly valuable. So thank you. With that, we have some time for questions and answers. And thank you to our listeners who have input some questions. And I'm going to group the first set of questions has to do with medication use during pregnancy. Maybe I can start with Dr. Clowse, since you just finished your presentation, and then Dr. Lightstone can add in as well, just for this first part. So the first question is in terms of your preferred antihypertensive. So Dr. Clowse, you mentioned, and also Dr. Lightstone, how important it is to control hypertension in the setting of pregnancy. We cannot use ACE inhibitors or angiotensin receptor blockers. What do you like to use?
So I'm going to be short, and then I want Liz to talk more about it as a nephrologist. I find that calcium channel blockers are most effective in this patient population. Our OBs in the United States tend to lean heavily on labetalol, but I find it to be, it's BID and it's harder to take, and you have to keep titrating it up, and it doesn't work as well. So that's my experience, but I want to hear what Liz has to say.
That's interesting. I mean, I think you're right, but we do tend to start with labetalol, and that probably has been driven by the OBs. But a lot of ours are on a low dose of beta blocker before they get pregnant, and we swap them to labetalol. The problem is actually it should be TDS, and that nobody can take TDS. So the nice thing about labetalol, it's got a very big dose range, so you can start little and work up and work up and work up. But we often use nifedipine and modified release, and if they're on amlodipine, I leave them on amlodipine, and I use doxycycline. Methyl-dopa, of course, worldwide is popular, but they do end up a bit miserable, and I have seen hepatitis with it, so I never use it unless I'm desperate. What I like to see, I mean, the most important, in fact, I saw someone this morning who's had terrible lupus nephritis recently, who's planning for pregnancy next year, and who does take her medicines, but she's not hypertensive. And I said, actually, that's a fantastic prognostic feature. Yeah.
Mhm.
And gold blood pressure.
A low blood pressure, not requiring, I mean, she's actually got too low blood pressure to be on RAS blockade, which is a problem when you're not pregnant because you would like her to be. But the fact that she's got lowish blood pressure makes me feel much better. And controlling. So I don't necessarily stop an ACE or an ARB before pregnancy if they've got regular periods. But I do tell them they've got to stop it as soon as they're pregnant because they must not be on it in the second and third trimester. But if I want to know what their baseline proteinuria is, or I'm worried I won't get control early enough, I change them before, and I might sometimes do a renal biopsy before pregnancy. So I see that I stop their ACE or their ARB, I see how much proteinuria they've got. If they've got a lot, I do a biopsy. But also I want to control their blood pressure before they're pregnant.
And Liz, that's a really important point because I find that I'm in that situation frequently. And can I ask you, just for all of us to understand better how you do it, what is that time period? So you stop the ACE or the ARB, let's say, you want to see where their proteinuria settles out. You want to understand if you have to get that kidney biopsy. But what are you like 3 months, 6 months? What are you, for our listeners, what are you thinking?
No, I think if you ACE and ARBs are washed out pretty quickly, so I don't. So I would probably see them within a month to 6 weeks, and if they've got a big bounce in their proteinuria, I would probably say, and I would plan that I would be biopsying them, so it doesn't become month. The real risk is it becomes months and months and months that you wait by the time you've got the biopsy and you've got the biopsy result, etc., etc. The other thing to remember is a lot of patients with renal disease these days will be on SGLT2 inhibitors, so dapagliflozin, and there's no data. They have to be stopped pre-pregnancy.
Got it.
Yeah.
Okay, very good. Thank you.
I'll add, Maria, that
yeah.
from the standpoint of switching the immunosuppressants, I prefer a longer period of wait time if I can get it. And it kind of depends on the patient, right? This patient looked like she was going to be really stable. I might have said like 3 months off of mycophenolate and let's see how you're doing, right? That might have been a reasonable approach. Somebody who had bad lupus nephritis a year and a half ago, but is just raring to go, I would try to convince them to give me a 6 to 9 month window of switched to pregnancy compatible meds if possible. It's hard to get those, but the longer the better in that situation.
But I would challenge you because I don't think AZA keeps them in remission well enough. So actually, I want to get them. I don't want them waiting too long that they flare because they're not on MMF. So it's a real balance. It's an art, not a science.
An art, isn't it? Yes. Okay, excellent. And on the topic of medications during pregnancy, we have a couple of questions here regarding B-cell depletion therapy. Number one is, and you covered this, but just to kind of reemphasize it again. So the first question is, which B-cell depletion? So now we have, of course, and Liz, you've done so much work with rituximab within your studies and steroid-free regimens, which I love. But now, of course, we have OB. So I think that this attendee is trying to get at that question, rituximab versus OB. And the second question regarding anti-CD20 is, when do we use it? And you both talked a bit about this, that we want to use it early before it, because it is an IgG molecule. It will cross the placenta second, third trimester. But maybe you could emphasize those points. So which one would you use and when?
Okay, so I've only used rituximab. I haven't. We're not allowed to use OB yet, but I think it's really difficult. So rituximab, most people are B cell replete by 6 months once you've given it to them, and as you say, it goes the transplacental whatever crossing goes up during the. So I'm delighted if they've had it just before they get pregnant. That's perfect, and not this business of wait a year till after you've had it. That's mad. And I will give it quite happily in the first trimester, but I try and avoid it second and third, not least because they're not going to make decent antibody responses to vaccines. Now, that's the problem with OB, because OB is much longer acting, assuming that it crosses in the same way. They're going to be B cell deplete for a very long time. And we say no live vaccines, but I'm not actually sure. We've done work in our immunosuppressant patients with a COVID vaccine. You just don't, if you're B cell deplete and you've never seen that vaccine before, you're just not going to make a response. So I'm really worried what we're going to be doing to the babies. And there's going to be a lot of women coming up who will have had OB, and we need to monitor these babies.
Yeah. I will echo that. I am in the process because we do have obinutuzumab now available to us in the United States. And so I am transitioning, I would say, from rituximab to obinutuzumab with the goal of getting the dose right as close to pregnancy or first trimester. Because the half-life of these drugs is pretty long, right? It's about 3 weeks. All biologics, it's about 3 weeks, right? And so if you go out like 5 half-lives, right, that's like a good half of a pregnancy, right? So if you were to dose it at 12 weeks, there will undoubtedly be some transfer to the baby, and the baby might be born with low B cells. I really hope that we can come up with a sort of approach where we're monitoring baby B cells and monitoring vaccine responses. I agree, because I think the chances, of pregnancy success and the babies being born at an older gestational age because of obinutuzumab is pretty high, but that there is potential risk. And I have not ever given a B cell drug in the second half of pregnancy. I have not been posed with that moment, but I haven't done it yet.
Excellent, thank you. I think we have time for two more questions. This will be a quick one. Liz, I'll turn to you on this. This is a question about how we interpret biomarkers in pregnancy. You mentioned that complement levels go up in pregnancy. But this attendee asked about how do we interpret a spot urine protein to creatinine ratio in the setting of pregnancy, or a spot urine albumin to creatinine ratio? Do we have to do the 24-hour urine? Can we rely on the spot? What do you do?
Never do 24-hour urines. I put women through years of misery for that before we got to PCRs. No, that's why you want to see them regularly and you want to see trends, because you can, if you have a bit of something, your PCR can go up. You're allowed microalbuminuria in pregnancy. So that's normal in pregnancy. I tend to monitor proteinuria, not albuminuria, but you're allowed microalbuminuria in pregnancy. So I don't get so worried. But again, it's trends. If they started the pregnancy with none and it's going up and it's going up and it's going up, then you start to worry. But a PCR greater than the equivalent of sort of 500 milligrams a day. So we've all got different units, but for me, that would be a PCR of 50. I think for you, it'd be 0.5, whatever.
Or 500, depends.
500, yeah, whatever. I know I'm bad on that. But so equivalent to half a gram a day would start to worry. And then once it's up to 1 gram, 2 grams and rising, then you get really worried. So it's trends are really important.
Trends. Yep. Yeah. Perfect. Okay.
Yeah.
And then let me turn this to you, Megan. This is a question about the juxta. This is in a woman who you're doing pre-pregnancy counseling in. She's in clinical remission, but she has, for instance, hypocomplementemia, or she might have an anti-DNA, but be clinically inactive. Would that be someone who you would preemptively start, let's say is just on hydroxychloroquine? Yeah. Do you feel like you have to normalize those biomarkers before pregnancy?
I don't normalize the biomarkers. When I've looked at data before out of Michelle Petrie's Hopkins data set. And if you had abnormal complement or double-stranded, but really no significant clinical disease activity, you really didn't have a dramatic increase in poor pregnancy outcomes. Maybe a small increase, but like not to the level of trying to add a bunch more immunosuppression and trying to normalize it and waiting 2 years of trying to do that. So I really think of them only in conjunction with disease activity, and that is really internal organ disease activity, primarily nephritis. So even like some mild rash and mild arthralgias and a mid positive double stranded, I wouldn't love that, but that's probably not going to harm her pregnancy outcomes. As long as she stays on her hydroxychloroquine, maybe give her a touch of azathioprine. Yeah.
And I know we're at time, but just with the one thing we haven't mentioned is belimumab, which a lot of these women will be
Yes.
on.
Yes.
I'm increasingly tending to keep them on it because it comes back to what Megan said so clearly. You want them to have controlled disease and you don't want them to flare. The data are that it is not teratogenic. There's not enough data yet, but the data suggests that it's fine. And actually, I think the EULAR guidelines have now changed their slant about not being on it. And for me, it's much more important to keep them well and not flaring.
Absolutely.
And you think about anifrolumab differently?
I don't have access to it, so I have no idea.
So that we don't have published renal data on anifrolumab that shows that it's beneficial, it makes me a little bit less enthused. But because I think the kidneys are so important, that's why I've really transitioned to continuing belimumab. I didn't used to continue belimumab when I didn't really think it did much for the kidneys. Now that I'm a believer that it's helping keeping people's lupus nephritis quiet, I am all in on continuing it in pregnancy, just with the goal of having not happen to Liz's patient, to avoiding that, right? That's what we're trying to avoid. And so I'm okay with belimumab. I actually am now continuing anifrolumab occasionally in patients who I really think are going to flare off of it, that I would need huge doses of prednisone, right? Like it's sort of the balance of like, does this patient really need this drug? Is there a safer option? If not, probably okay-ish.
Okay, great. Well, thank you both very, very much for answering those. Those were excellent questions by our attendees. And we are at the top of the hour, and I would just like to close now and thank all of you for joining us for this, I thought, to be an incredibly educational webinar. As I said, I learned a lot. Thank you, Dr. Clowse and Dr. Lightstone, for sharing your wisdom with us today. We ask that you please fill out your evaluation form and give us your feedback. We take your feedback very seriously, and we plan content based upon what you tell us. So please take the time to do that. We love to hear from all of you what we can be doing better, what we can be doing to help you in your practice of patients living with lupus. And then lastly, the live stream version of the webinar will be available to view on the Lupus Forum YouTube channel. Please take a look at it, refresh some of this knowledge. I think it will be very helpful. And with that, we will close. Thank you all again, and we'll see you next time.